associated with being vaccinated that puts individuals at increased risk of exposure to the virus before the immunity kicks in from the vaccination. The data from the RNA vaccine seems to show that it takes at least 14 days for there to be substantial protection against infection from the RNA-based vaccines. And that protection continues, especially as one gets a second dose. There are no data to suggest the RNA vaccines are 95% efficacious if you only get one dose. There are no data to support that. All the data we have is in a 2-dose regimen. So I just want you to keep in mind, as individuals are getting vaccinated, that it's incredibly important to continue to stay safe. Thank you very much.
Thanks, Cap. I don't see any questions, and the hour is late. What a wonderful, comprehensive story that you've given us. And congratulations, Mount Sinai. You guys, you rock. You really do. I'm going to now remind everyone that we have a totally different symposium that's going to be projected in the next couple of hours. I'm going to go up on the podium once it's clean. We have been partnering with a CME company called Academic CME to put on extra lectures during our Eastern Pulmonary Conference. And Academic CME has been very kind enough to invite these speakers. As you'll see from your program and inside your bag, there is a card here. If you want CME, make sure you take your phone and click on this lower right-hand symbol, and that will allow you to get the CME credits for this. So I think I'll jump up on the stage now, and we'll begin the symposium. Good morning, everyone, and welcome to this symposium sponsored by Academic CME here at this Eastern Pulmonary Conference meeting in Palm Beach, Florida. And we're very pleased to have 3 absolute leaders in the field on 3 different topics this morning for you. The first speaker this morning will be Dr. Charles Daly. Dr. Daly is the Chief of the Division of Mycobacterial and Respiratory Infections and professor in the Department of Medicine at National Jewish Hospital in Denver, Colorado. He is a leading researcher and clinician in the field of non-tuberculous mycobacterial lung disease, and he will discuss with us recent advances to improve the diagnostic accuracy and patient quality of life. Following his discussion, please type in your questions, and I will be back at the podium to relay your questions to Dr. Daly. So Chuck, where are you? All set?
It's a pleasure to be here today. Thank you very much. I'd like to thank Dr. Brayman for the introduction and also for the invitation to speak at this year's conference. I was asked to speak about advances in non-tuberculous mycobacterial lung disease, specifically looking at improving diagnosis, treatment, and quality of life. This is a great time to discuss this, given that we have recently published new guidelines. The agenda today is as follows. We'll briefly look at epidemiology, clinical manifestations, and risk factors for NTM lung disease. Then we'll focus on the diagnosis of NTM lung disease, specifically reviewing the diagnostic criteria. We'll look at the review of current treatment recommendations that are included in the new guidelines, and then focus a little bit on the personalized treatment and how we improve the quality of life of our patients. So the learning objectives follow. We'd like to understand the epidemiology and the clinical manifestations of NTM lung disease, as well as the risk factors for disease, understand guideline-based diagnostic criteria and the importance of the laboratory in the diagnosis of NTM lung disease, describe current treatment regimens, and describe treatment goals and the importance of adherence to the treatment regimen and also quality of life. Here you can see the accreditation statement and credit designation statement. Also additional CME credit activity information. And these are my disclosure of conflict. You can see at the bottom that I've served as a consultant or advisor to the companies listed here, and also received research and or grants from INSMED and Sparrow. So let's begin, make sure we're all on the same page. What are non-tuberculous mycobacteria, or NTM, from now on? Well, these are environmental bacteria that have been found in soil and water, both natural and treated waters. They can produce both pulmonary and extrapulmonary disease, but the pathogenicity varies greatly among the species. There are high levels of in vitro resistance across the species, which makes treatment complex and associated with suboptimal outcomes. There are now approximately 200 mycobacterial species, and almost all of these are considered NTM. These species are causing a great deal of disease, so we see a high prevalence of NTM lung disease. It is increasing in some areas. Now, the prevalence is highest in older ages in women in almost all studies. NTM prevalence is higher than TB in many studies, including the United States and Canada, but also other countries like Japan and South Korea. Bronchiectasis appears to be the greatest risk factor for the development of NTM pulmonary disease. And NTM pulmonary disease is increasing in prevalence in many areas. And to highlight that is a recent publication from Kevin Winthrop at Oregon. He and his group looked at a national managed care claims database. This was the database Optum. It includes about 27 million people annually. And what you see plotted here is the NTM lung disease prevalence across this time frame of 2008 to 2015. The top line are those who were 65 years and older. And as you can see, going back to 2008, the prevalence was about 30 per 100,000, and that increased significantly to over 45 per 100,000. The line right below that are those enrolled in Medicare, so also related to older age. The third line are women. That is the other group that has a higher rate and also statistically increasing over this time frame. So who gets NTM lung disease? If these organisms are so ubiquitous that they're in our soil and water everywhere, why don't we all get ill? Well, it looks like there has to be some degree of susceptibility in most cases. Underlying conditions like cystic fibrosis, alpha-1 antitrypsin deficiency, COPD, pneumoconiosis, collagen vascular diseases, top of the list bronchiectasis, and then other forms of immunosuppression or lung disease. There's this interesting group that must have something wrong with their innate host issues, and these are often called Lady Windermere syndrome. These are mostly women, postmenopausal, thin, with a distinct body habitus. And we would say these two groups are susceptible groups. Now, there's another group, probably not as common, that may have no susceptibility, but probably because of very significant exposures to aerosolized water, soil, maybe even just living in an endemic area, puts them at increased risk. And this has been called the unusual dose model. But let me point out that most people who develop NTM lung disease are susceptible. So why is it important for us to diagnose these patients early and get treatment started? Well, we know disease progression occurs in about 60% of persons who meet the ATS-IDSA criteria for disease within about a 3 to 5 year time frame. These are at least 3 of the studies that have demonstrated that. We also know that lung function declines. We showed with Park and Wonjin Ko in Samsung Medical Center in Korea that lung function does decline over time. This has also been replicated by others. And the 5-year mortality can be as high as 10 to 33% and higher than the general population's mortality. And the mortality seems to be higher in untreated MAC than treated MAC. And again, there are multiple studies. These are just three that I've listed that address the high mortality in these patients. So whether it's disease progression, worsening lung function, or ultimately mortality, it's important that we make an early diagnosis and get treatment started early. Now, most patients will present with one of two clinical phenotypes, nodular bronchiectatic disease, typically women, older, non-smokers, and they have the phenotype I mentioned before. They're tall, they're thin, they have a low body mass index. Here you see a picture from a study published by Kim that showed in every way that they measured them phenotypically, they were different than women who did not have NTM. The CT scan you see is also pretty typical with primarily right middle lobe and lingular bronchiectasis, although it can be scattered in all lobes. The next phenotype, which has been referred to as the classic phenotype because it was one of the earliest noted, actually are older males who do typically smoke. And they have various body bills kind of based on their COPD phenotype. Here you see a chest x-ray show right upper lobe cavitation and volume loss, looks just like tuberculosis. And these patients often enter our healthcare system through a TB clinic. Now, symptoms, most of the symptoms that have been described more recently come from patients with more nodular bronchiectatic disease. Fatigue is often top of the list. Right there next to it is cough, often a productive cough. The other symptoms are more variable. Weight loss is common because this is a subacute to chronic illness. And unfortunately, one part of the delay in diagnosis in this disease relates to the symptom onset to diagnosis. And in this study, it was 10 months, but it ranged from 1 month to 6 years. And there are other studies suggesting that it could be even longer time frames that really slow down our ability to diagnose this disease. Now, just growing an NTM from a respiratory specimen, unlike with TB, does not meet disease criteria. And in the 2007 ATS and IDSA guidelines, we came up with these diagnostic criteria. They begin with a symptomatic patient with pulmonary or systemic symptoms. They have a radiograph consistent with NTM pulmonary disease, just like the ones I showed you. They should have both of these, both clinical and radiographic findings. This assumes we exclude other causes of these potential findings. But ultimately, this is a microbiologic diagnosis. It requires at least 2 separate sputum specimens to be positive, and they should be positive with the same species. That brings in the laboratory, which needs to be very precise in their speciation. In patients who we cannot get a sputum or whose sputum are negative and you still suspect pulmonary NTM, positive cultures from at least one bronchial wash or lavage do meet disease criteria, or if you have a transbronchial or other type of lung biopsy and a respiratory specimen that grows an NTM. That meets disease criteria. But most of us who've been doing this a long time really focus on sputum. It is more predictive of progression and I think more helpful clinically than a single isolate from another specimen. So we need the lab. So we think about it, and then we collect our specimens, we wait for the cultures, speciation, drug susceptibility, and as you know, this takes a long time. It can take 2-3 months, sometimes longer, which is really also unacceptable because it really delays the diagnosis even further. So let's think about specimen collection first. Let's go with bronchoscopy because I don't think it's as good as you think it is. We know lidocaine is bacteriostatic. We know the specimen from a lavage or wash is diluted with saline. Sampling error can occur because you have to pick where you're going to take your samples. We're not able to determine bacterial load as we can with sputum. And of course, there's the risk and the cost of bronchoscopy. What about sputum? I think it might be better than you think. With sputum, you can get multiple specimens. The current new guidelines recommend 3 over at least 1 week, but I would say preferably over several weeks. We know that sputum AFP smear positivity and the number of cultures that you obtain that are positive are associated with progressive disease. We also know that there's similar culture yield with sputum and bronchoscopy. We know this better with tuberculosis, but the largest study that looked at NTM showed no difference in culture yield between bronchoscopy and sputum. And you can now do sputum induction anywhere. You can do it at home. We show our patients how we do it here, and then we send them home with an aerobica and hypertonic saline, and they're able to do sputum induction at home, and the yield has been very high. So we feel like the best way to make the diagnosis is with sputum. So now you've thought about it, you've collected your specimen. Now what you're waiting for are your culture results. We recommend that both liquid and solid media be obtained because solid media added to liquid media increases the sensitivity about 15%. Now, identification is very important because we have these 200 species we need to somehow identify. This will require usually a molecular-based or MALDI-TOF approach. But to really be able to subspeciate Mycobacterium abscessus, for example, you will need some type of molecular approach. And of course, we're waiting for drug susceptibility testing. The new guidelines defer to the CLSI guidelines. There are two documents that relate to drug susceptibility testing and NTM, both in terms of methodology and which drug should be tested. So for MAC, which is what I'm going to focus on today, phenotypic testing takes weeks. And what you're going to be testing based on the CLSI and now new guidelines is the macrolides and amikacin. These are the only two drugs for which we have some idea of a resistance cut point that correlates with clinical outcome. For the macrolides, clarithromycin is the class drug. It's just easier to work with, but it's almost 100% concordant with azithromycin. You can see that resistance is defined as a MIC of 32 or greater. And importantly, there are now two cut points for amikacin, one for the intravenous or parenteral formulation, the other is for liposomal. And you can see those are different. 64 or greater for parenteral amikacin, but that increases to 128 or greater for liposomal. We can speed this up though by using genotypic testing, where we can get the results in hours and days. These are two publications, one that I was involved in South Korea. Here what we're looking at are mutations for macrolide and amikacin, using again a line probe approach. And you can see for macrolide resistance, it's 100% sensitive and specific. There's been variability in the literature regarding sensitivity looking for amikacin ranging from 50 to 75, but in these two publications that reported this, they had very few, for example, 2 resistant strains. In our lab here, we do use this technology and it's over 90% sensitivity and specificity 100%. So we think we already have methods that can speed this up, this identification process of macrolide and aminoglycoside resistance to within hours to days. Now, what about treatment? So we have new treatment guidelines. These were sponsored by 4 societies that you see here: the American Thoracic Society, the European Respiratory Society, the European Society for Clinical Microbiology and Infectious Diseases, and IDSA. This was put together. First step is to bring together an expert panel. We had 17 expert or content members, 2 methodologists, 1 medical librarian, and a patient advocate. First step in developing guidelines is you have to scope the guidelines. This is a very large field. We decided to focus on pulmonary disease in adults who are not immunocompromised and do not have CF because there are other guidelines that address those populations. And of those 2,000 species, we had to focus to the most common that cause pulmonary disease. That was MAC, Kansasii, Xenopi, and abscessus. And unlike the previous 2007 guidelines, we used grade methodology. This is a very rigorous approach that has been used for many guidelines. And that led to 22 PICO questions and 31 recommendations, 7 of which relate to MAC, and I will review in a moment. But unfortunately, among all these recommendations, there were only 4 that were strong. And in those settings, we can use the word recommend. For the conditional or weaker recommendations, we have to use the word suggest. But I wish we had more evidence so that we had more strong recommendations. And hopefully for the next guideline, we will. So one of the first questions as a clinician, your patient grows one of these organisms, and you have to decide, do I treat or do I do watchful waiting? We suggest in patients who meet diagnostic criteria for NTM pulmonary disease that you initiate treatment rather than watchful waiting, but particularly in the setting of someone who has a positive AFB smear and or cavitary disease. Now, in our deliberations, we note there are both host and organism factors that relate to progression. For example, some NTM species don't cause disease and some do quite frequently. And immunocompromised individuals are more likely to progress than those who are not. But we have data now from cohort studies that show that bacterial load and radiographic extent of disease are important predictors of progression. As you can see, there are others that have been identified, like older age, lower body mass index, which is very common in these patients, comorbidities, low albumin, anemia, inflammatory or elevated inflammatory indices. All of these have been associated with progression. This is just an example of a study that looked at almost 500 patients with MAC pulmonary disease who met the previous ATS and IDSA criteria. And over 3 years, 2/3 of them progressed, 24% were stable, and about half of those spontaneously converted. And again, risk factors that we see here on the left were associated with progression in this study and other studies. So I think these are helpful in that initial clinic visit to help you figure out, should we begin treatment now or continue to follow the patient? So I would say, if you decide to do watchful waiting, don't just watch and wait, do something. So when we say we're not treating them, we mean we're not treating them with antimicrobials during that watching and wait, but we are going to initiate airway clearance or improve it, evaluate and treat GERD, manage any of their comorbidities. Importantly, particularly in those who have body mass indices that are low, to improve their nutritional status. And we're pretty aggressive about treating other concurrent infections like Pseudomonas or staph to see how much benefit we get. And there are multiple reviews, Cochrane reviews, systematic reviews that have looked at the benefit of airway clearance in patients with bronchiectasis. There's only one study, however, that's looked at airway clearance in NTM lung disease from NYU. This was a retrospective review of 77 patients with NTM lung disease who did not undergo antibiotic treatment. They looked at the evaluation of the effect of chest physiotherapy, which was started in about 50% of their patients at baseline. And by chest physiotherapy, they were kind of all inclusive, aerobicas, vest, in any kind of chest physiotherapy. But they did show that cough improved. Of the things that they followed, that was probably the most important finding. This improved across 24 months in those who received chest PT. You can see in the figure on the right, the frequency of cough across the time frame. The top is no chest PT and the bottom is chest PT. There was also an increase in the percentage of change of total lung capacity in those that received chest PT. So in a small study, there does seem to be some benefit of just introducing airway clearance, at least early on, and this certainly works in some of my patients. Of course, there are others who will progress despite this. So which regimen would you build? Would you use a macrolide or not? We recommend a 3-drug regimen that includes a macrolide over a 3-drug regimen without. This is one of those few strong recommendations. We made a strong recommendation, even though we have no well-designed studies that have addressed this, but we have decades of consistent cohort studies that show macrolide susceptibility has been a strong predictor of treatment success. And if you lose the macrolide due to resistance or intolerance, there's a really markedly reduced rate of sputum conversion from about 80% to 5 to 36%. We had a systematic review that included 21 studies to review as part of our evidence base, and this showed that sustained culture conversion was more common in macrolide-containing regimens, and that difference increased as the study quality improved. So we recommend a macrolide regimen. So which one do we recommend? We suggest a azithromycin-based treatment regimen rather than clarithromycin. Now, there's no randomized studies. There is one occurring now in France, but we looked at cohort studies, and there was equal efficacy across the cohort studies. Generally speaking, azithromycin was better tolerated. It has less drug interactions than clarithromycin, has a lower pill burden, and it's single daily dosing. So we felt that that would suggest it would be a better agent to use. And for evidence, again, we use this same systematic review. No difference in sputum culture conversion at these time points, going through even sustained conversion, and no difference in acquired macrolide resistance. If you can't get azithromycin or it's not tolerated, certainly clarithromycin is a reasonable alternative. What about aminoglycosides? So we suggest for cavitary or otherwise advanced severe bronchiectatic disease or macrolide resistant disease that parenteral amikacin or streptomycin be included in the initial regimen. Here we did have a randomized study, only one. This is a placebo-controlled trial. It compared macrolide-based 3-drug regimen with intramuscular streptomycin versus placebo for the first 3 months. And there was a higher rate of culture conversion in those who received streptomycin. We also know from those previously mentioned cohort studies that we see higher culture conversion in those who have macrolide-resistant disease when they receive an aminoglycoside, often prolonged, like 6 or more months. This is just to show you the study from Japan. This was that randomized study, and you can see in those who received streptomycin, about 70% of them converted. They divided this into avium and intracellular and saw no difference in outcome. And among those who received placebo, it was only about 50%. So a pretty significant bactericidal activity early in the course of therapy. So in these more severe, difficult to treat patients, we thought that this should be recommended. Now that brings up inhaled amikacin. And this is the first time the guidelines have addressed this. There are 2 recommendations. So in patients with newly diagnosed MAC pulmonary disease, we suggest neither the inhaled parenteral formulation of amikacin nor amikacin liposome inhalation suspension, or ALIS, be used. However, in patients who are treatment refractory, defined as they're still culture positive after 6 months of guideline-based therapy, we do recommend, and this is a strong recommendation, the addition of ALIS to a standard oral regimen. It's important to recognize we have no data related to the use of amikacin in treatment-naive patients, hence we could not make a recommendation there. And we focused on the second recommendation. Because we have 2 randomized trials, the phase 3 trial was called the CONVERT study. This was a randomized controlled study of ALIS in the treatment of treatment refractory MAC disease. And what you see here, the percentage of patients who culture converted from baseline through month 4. And it's pretty easy to see in those who received ALIS, which are the darker bars, we start to see separation at about 1 month with improved culture conversion. And this continues throughout the study. And at 4 months, almost 30% who received ALIS culture converted versus 9. And this was an extremely difficult to treat population. The median time on therapy was at least 3 years of therapy. Yet we were able in 6 months to be able to convert 30% of those. But if you just continue doing the same thing without another intervention, almost nobody would convert. So this is a new recommendation in the guidelines. A very common question is 3 versus 2 drugs. How many do you need? Well, in patients with macrolide susceptible MAC pulmonary disease, we suggest treatment regimen with at least 3 drugs, and those 3 drugs should include at least a macrolide and a ethambutol over a 2-drug regimen, which if you use would be a macrolide and a ethambutol. We do not recommend a macrolide and fluoroquinolone or macrolide and rifampin alone because those have been associated with higher rates of macrolide resistance. Now, most studies have evaluated 3 drugs, so we did not have a large evidence base with 2. We did have 1 randomized study from Japan that compared 2 versus 3 drugs. Unfortunately, it was a small study. It was underpowered. It had several weaknesses in its design and methodology. We were also concerned about the potential development of macrolide resistance with only 2 drugs. However, we're intrigued by this because these are the efficacy data from that trial. And the intention to treat, the 2-drug regimen was non-inferior to the 3-drug. That did not stand up in the per protocol, but there was very large amount of dropout, and only half the patients who enrolled were actually available for analysis at the end. But it does look like this may be an active regimen. And this has led to a large 30-site study here in the US that is hoping to enroll over 400 patients comparing 2 versus 3 drugs. And so hopefully for the next guideline, we will have very rigorous data for our evidence base. Do you give this intermittently or daily? Two recommendations. If it's non-cavitary disease, we suggest 3 times a week therapy. However, with cavitary or otherwise severe advanced disease, we recommend daily therapy. Again, this comes from cohort data, which have demonstrated similar culture conversion rates with intermittent versus daily therapy. We know intermittent therapy is associated with less adverse events and has higher completion rates. There's no evidence of increased risk of macrolide resistance. However, in cavitary disease, we see very low culture conversion with intermittent therapy, hence the recommendation not to use it in cavitary disease. And the final question that relates to MAC is, how long should you treat these patients? We suggest that patients receive treatment for at least 12 months after culture conversion. Yes, this is exactly what we said in the 2007 guidelines, because unfortunately, we have really a plethora of evidence to help us here. We have no randomized studies that have looked at this. We have some cohort data saying that treatment success is higher in persons who received 12 or more months of therapy compared with less than 12, but they didn't look at beyond culture conversion. The only one that has done that was a post-marketing study in Japan that showed bacteriologic relapse was 5% in people treated less than 15 months after sputum culture conversion, but 0 in those who got more. But I'll show you that study. Here you can see the number of patients who recurred. The gray bars are those who recurred over the duration beyond culture conversion. And as I mentioned, if you look at the red bar at 15 months, you can see they all occurred under 15 months. But if you go to the right of this figure, you see there aren't a lot of patients that were included in the study. So it's not a definitive study. It suggests that we're probably out somewhere in the right duration when we say 12 months beyond culture conversion. It's a very high research priority. So we're left with this. We have 3 different phenotypes with 3 different regimens. In nodular bronchiectatic disease, we recommend 3 drugs, macrolide containing, azithromycin preferred. This be given 3 times weekly. In cavitary disease, 3 or more drugs. The 4th drug would be parenteral amikacin or streptomycin. Here we give the drugs daily, except the aminoglycoside, which can be 3 times weekly. For refractory disease, this would be 4 or more drugs. That 4th drug would be inhaled amikacin. If there was cavitary disease, you could still consider starting with intravenous and then transitioning to inhaled. This would also be daily therapy. You may need alternative drugs. We listed clofazimine, moxifloxacin, linezolid. I listed bedaquiline, although that's not specifically in the guidelines. It's a drug that we have used when we needed an alternative drug. So what are the goals of therapy? Well, from the provider view, we're trying to improve our patient's symptoms, improve pulmonary function, culture convert them. Obviously, we're trying to cure them. It's not always possible. And if we can't, we're trying to slow or stop progression. What about patients? What do they want from therapy? Well, there was a 57-question survey that was sent out by NTM-IR, which is a patient foundation here in the U.S. 465 U.S. NTM patients responded, so that's quite good. And one of the questions was, if your treatment could change one thing about your NTM lung infection, what would that be? And these were the top 3: culture conversion, less coughing, less fatigue. So they would like to feel better, and they'd like to culture convert. And why would they mention that? Well, they know that the duration of therapy is related to this. And they know that the definition of treatment failure is related to culture conversion. So we actually do have similar goals between provider and patient. And in order to achieve those goals, the other thing we need to understand is, how do we measure quality of life in patients? We don't have a lot of studies. These are 4 studies. There are others. Most of them are pretty small. They use different instruments. And I'd just like to focus on the last 2, the bolded ones, because these are the only 2 that looked at the impact of treatment. So all of the studies show that at baseline, quality of life is lower in patients with NTM pulmonary disease than another population. But we want to know, does treatment impact that? And both the study by Chaya here at National Jewish demonstrated in M. abscessus patients an improvement at 12 and 24 months in quality of life measure using the FS36. And Hinkle, recently in the largest study, also showed using QoL-B, which is a bronchiectasis quality of life with what's called the NTM module, that there was also treatment-associated benefit in several different domains. So this is a very important area of research for us, is to be able to measure quality of life, but it looks like in the early studies that we are seeing a benefit from treatment. So with a patient-centered approach, we want to use a multidisciplinary approach to therapy, addressing all of these issues that I've listed here. It's very important to review the treatment and the realistic expectations, in particular goals of therapy. I think this is how you keep people on therapy when they really understand what it is you're aiming to achieve. We'll review how we're going to measure that achievement. Current recommendations are to get sputum every 1 to 2 months because you're going to need that information to determine the duration of therapy, and also at 6 months to determine whether a treatment failure and whether ALIS should be added. And it's very important to review side effects of the medications, the plans for monitoring, and what the possible interventions may be. Things like drug holidays, give them a break for a week or two, but make it clear to them that there are alternatives if we can't use the standard 3-drug regimen. We do have options. I'll end with just future things that are happening. There are various antibiotics and approaches. AirCase, now approved for the treatment of refractory MAC, is going into trials as we speak for treatment naive MAC, and also subsequently a trial for M. abscessus. SPR 720 is a drug made by Spiro. It's a gyrase inhibitor, and it is, I believe they've enrolled their first patient for a MAC trial. Bedaquiline, I mentioned, clofazimine, also in study. Omadacycline, we believe will be going into trial next year for abscessus, and the use of dual beta lactams for the treatment of abscessus are now beginning to be studied. Other things like inhaled nitric oxide, a phase 2 study is starting in Australia early next year, and bacteriophages, particularly for abscessus, but now also patients with MAC are beginning to be evaluated. So these are some of the things that are coming our way literally as we speak, with more to come. So I'd like to thank you for your attention today, and I hope we have time for questions.
Super. Chuck, thank you for that outstanding presentation, and also thank you for all the work you've done on the guideline committees, giving us the roadmap to treat this most difficult disease. We have a number of people who I know are online at home, and they're going to be emailing me, or texting me rather, any questions that they have, and here, anyone in this room can text me also. Chuck, I'm going to start with the first question. It's a hard one. I've been, as you probably know, in practice for many years, decades, and these mycobacterial infections were kind of a rarity when I was starting out in my pulmonary world. Yet, when I left Mount Sinai a number of months ago, I was seeing 3 patients a week at least, and I was not seeing most of these patients. We had a specialized center for mycobacterial disease that I would refer to. So what's going on? You showed us in the Winthrop study published in the Annals last year that rate is going up. What's happening in our world? Is there more of it in the ground, in the soil? Is it just we're getting an older population, sicker population? And what's this with women? I mean, why is it more likely in women? Your answers, please.
Well, those are very important questions, and I don't know that I have any definitive ones. I have thoughts. It's not just in the U.S. We see increases in Canada, some parts of Europe, Japan, Korea, Taiwan, Australia. So this is a global phenomena of increase. Some people think it's just because awareness has increased, but I think it's more than that. In fact, in the Netherlands and Canada, they've looked at this and showed increases were occurring, for example, before they introduced liquid culture into the country. So I do think that there's more to it than just looking for it, and more to it than just better culture systems. Now, a lot of things have been happening. We turned our hot water temperature down, decades ago to prevent scalding, save energy. And we know that these organisms eventually do not do well if it's hot enough, over 130 to 140 degrees. We see less of these in our home water. We changed from copper piping to PVC, also as a cost element, but PVC allows biofilm to produce or to be formed better than copper can do. We have an aging population. We're immunocompromising people. We're certainly getting more exposure because we're getting exposed more to, for example, aerosolized water. And one thing that's very important to note is that if you look at the concentration of these organisms, they increase as we go from nature to our homes. So, when we're taking a shower every day or showers at home and the gym, we're just getting exposed to these more and more. So it's probably a combination of all of those things. More susceptible hosts, more of these organisms in our water, and also more exposure to them. Now, why women get it? That's a very interesting research question. And honestly, we don't know the answer to that. There are some studies that have looked at issues related to hormonal environment in mice, for example, that are suggestive that there may be a hormonal component, but we really don't know why this is happening.
You mentioned on one of your slides that we need to pay attention to concomitant infections like bacterial infections, and you actually mentioned Pseudomonas as one of the superinfectors. So my question is the following. Would it be any advantage in initiating therapy to put a patient on maybe a broader spectrum antibiotic to reduce the bacterial load, and would that help in the treatment of the NTB?
Well, I do think it's worth treating concomitant infections, either even before you start therapy for the non-tuberculous infection. Sometimes, for example, with Mycobacterium abscessus, we'll pick a regimen, for example, imipenem, that will get Pseudomonas and abscessus and add that to our multi-drug regimen. It's a bit of our approach with cystic fibrosis patients. We really want to hit the concurrent infections well, and sometimes that will leave us this responsibility of having to treat the NTM for a while. Kind of correlating with that is just good airway clearance. So whatever the infection, whether it's Pseudomonas, Aspergillus, abscessus, all of these, I think, benefit from good airway clearance. So the answer is yes, I would treat the concurrent infections. I don't know if it's always, well, I know it doesn't always impact the NTM, but in some cases, cough improves dramatically, and now the symptom that you were pointing your finger at the NTM is no longer pointing at the NTM. It was the Pseudomonas that was causing a lot of the symptoms. And now I don't have to treat the NTM.
Super, thank you. Seeing no other questions, either from the audience here in Palm Beach or those who are online, let me just once again thank you, and we'll go on with our program. Chuck, it's been a great pleasure. It's really been terrific.
Right.
Thank you.
Thank you. Bye-bye.
Okay, we are going on with our symposium with another topic, which I think is really red hot, and a presenter who is just absolutely tops in her field. She is a professor of medicine and the Division of Pulmonary Critical Care Medicine. She's a co-chair of the Multidisciplinary Thoracic Oncology Program and director of Lung Cancer Screening Program, University of North Carolina, Chapel Hill. Dr. Patricia Rivera, actually a previous presenter here at the Eastern Pulmonary Conference. So Patricia, thank you for joining us this morning, and welcome.
Thank you. My name is Patricia Rivera, and I'm going to be speaking today on the role of immunotherapy in the treatment of lung cancer. Just to review the agenda, we will review briefly the science of anti-PD-1 and PD-L1 based therapy in non-small cell lung cancer, the clinical trials that have reviewed the data for these treatments, and how to manage patients in general with advanced non-small cell lung cancer. Again, the learning objectives is to understand how these therapeutic agents work, the current clinical data available that supports the implementation of these agents in the treatment of advanced non-small cell lung cancer. This lecture will provide CME credit for those of you who are participating. These are my disclosures. I had prior advisory board member disclosures, which I no longer have. I have no honoraria since January 2020, and I do have funding through the NIH and NCI. I have no conflict of interest pertaining to this lecture. This activity is supported by educational grants, as you see above. And again, the activity is provided by academic CME. As many of you know, the majority of patients who are diagnosed with lung cancer are diagnosed with advanced disease. The majority of lung cancers are non-small cell lung cancer, and about 55% of patients will present with distant disease at the time of diagnosis. The majority of patients will present with distant disease when they're diagnosed with small cell lung cancer. It took many years for lung cancer to sort of join the crowd, if you will, of targeted therapy or precision medicine. But eventually, lung cancer moved to the front line of this innovation. In 2002, we thought of non-small cell lung cancer as a single disease, and that changed with the appreciation that we needed to understand the histology better and identify the histology better, either squamous cell or adenocarcinoma in non-small cell lung cancers, because we learned early in 2000 that adenocarcinomas, a subset of these tumors, were characterized by specific molecular aberrations, and that led to the discovery of specific targeted therapies to these molecular aberrations, and that really shepherded the era of precision medicine in non-small cell lung cancer. But in 2005, we entered a new dawn, and that was the dawn of immunotherapy in the treatment of non-small cell lung cancer. Up until that time, progress had been made in other diseases like melanoma and renal cell cancer, but very little data was available in non-small cell lung cancer. I urge you all to read this article. It's an older article from 2013, but it's a really wonderful description of the cancer immune cycle and describing the immune cycle as a cyclical process. It is a self-propagating process that leads to stimulatory factors that amplify the T cell response. And that's important because augmenting our own innate immunity is a very important inherent protective factor that we have against cancer. But this cycle is also characterized by inhibitory factors that can halt the development or limit the enhancement of our own innate immunity. The cycle is divided into 7 major steps that start with the release of cancer cells, the release of antigens by cancer cell death, and it ends with the killing of cancer cells. And at each step of this cycle, the role of specific interventions and therapeutics plays different roles. Immune checkpoint inhibition in lung cancer is divided into 2 categories, if you will: central or lymphoid, like thymus cell, and peripheral tissues, such as peripheral lymphocytes throughout our body. In central lymphoid organs, T cells express CTL4 or cytotoxic lymphocyte antigen 4 antigens, and these downregulate or hamper, if you will, T cell function. If we block those antibodies with if we block those antigens with antibodies, then we can reverse that downregulation. Most of the data evolves around the peripheral T cells, or the PD-1 and PD-L1 proteins, which are again expressed on T cells. Cancer-presenting cells and cancer cells will develop or release, if you will, the ligands that bind to these proteins. And when that happens, when there's ligand binding to the PD-1 protein, you get downregulation of the immune system. And by blocking that ability of the ligand to adhere to the PD protein, then you can restore, if you will, T cell immunity. So again, on the T cell and the peripheral T cells, Program Death 1 is expressed on the surface of the T cell. The tumor cell or the tumor presenting cell, which is the dendritic cell, present the ligands, PDL1 and PDL2. If we block the binding of the ligand to the program death receptor, we enhance, if you will, or restore our anti-tumor cell activity, which is critically important in carcinogenesis. We currently have 4 program cell death checkpoint inhibitors that are used and have been approved for the treatment of advanced lung cancer and locally advanced lung cancer. The 2 program death inhibitors include nivolumab and pembrolizumab, and the program death ligand inhibitors are atezolizumab and durvalumab, difficult to pronounce. And I'm going to cover the data on these 4 agents across the spectrum of advanced and locally advanced non-small cell lung cancer. The first introduction to immunotherapy and lung cancer was in the second-line setting in patients with either squamous cell non-small cell lung cancer or non-squamous cell non-small cell lung cancer who had undergone conventional chemotherapy and had failed or had recurrence of disease. Nivolumab was investigated in both of these tumor subsets. And importantly, compared to second-line docetaxel, which at the time had been the standard of care when patients relapsed, nivolumab demonstrated an improvement in median and 1-year survival, primarily in patients with squamous cell carcinoma of the lung with a hazard ratio for death of 0.59, but also with a 1-year improvement in survival from 9 months with docetaxel to 12 months in patients with non-squamous non-small cell lung cancer. And this was really a significant breakthrough in the treatment of advanced non-small cell lung cancer. And in 2015, nivolumab was the first immunotherapy agent to be approved for second-line therapy in advanced non-small cell lung cancer. Early on, we appreciated that in addition to understanding whether a patient had squamous cell cancer or adenocarcinoma, and importantly, whether it was an adenocarcinoma that expressed EGFR or ALK or ROS, we appreciated through data that a subset of patients with non-small cell lung cancer overexpressed the program death ligand 1 in their tumor cells. And it was important to identify these patients who overexpressed PDL1 because that was a subset of patients that was found in phase 1 studies to perhaps have a better response to first-line therapy with immunotherapy. And that led to the investigation of pembrolizumab versus chemotherapy in the first-line setting in patients with advanced non-small cell lung cancer who overexpressed program death ligand 1 on their tumor cells. In this study, the estimated overall survival at 6 months for pembrolizumab was better compared to patients who had received first-line chemotherapy. But importantly, in the updated results of the Keynote 042 study, which was published in 2018, overall survival at 24 months was significantly better in patients who overexpressed PDL1 when they were treated with pembrolizumab compared to chemotherapy, 20 months compared to 2 months for those patients who have received chemotherapy. Following the results of these studies, pembrolizumab then received approval by the FDA for first-line treatment in advanced non-small cell lung cancer in patients who had a PDL1 score of greater than or equal to 50%. Recently, we were presented with data that summarize the overall response, not only median overall survival, but 5-year survival data in patients with advanced non-small cell lung cancer treated with first-line and second-line pembrolizumab. And this is the graph for overall survival in patients treated with pembrolizumab in the first-line setting. This is patients treated with pembrolizumab in the second-line setting. And then patients who overexpress PD-L1 and those who have less than 50%. And this is really remarkable. For treatment-naive patients, pembrolizumab in patients who receive it in first-line therapy, overall survival 22 months, 10 months for those who received it in the second line. 5-year estimated survival, 5-year in advanced non-small cell lung cancer, 23%, and 29.6% for patients who overexpress PD-L1. So this is really remarkable when you think about non-small cell lung cancer, a disease that for the most part, the majority of 55% of patients present with advanced disease. Advanced disease is treatable but not curable. We are now seeing data that a subset of these patients can achieve 5-year survival, and this is pretty remarkable. Very recently, we were presented with data on atezolizumab, which is a PD-L1 inhibitor in the first-line setting in patients who overexpress PD-L1. 572 patients with advanced non-squamous or squamous cell cancer who did not express either EGFR or ALK or any other molecular target were randomized to platinum-based chemotherapy versus atezolizumab in the first-line setting. The primary endpoints were overall and progression-free survival according to PD-L1 expression. And again, we see the significant benefit of first-line therapy in patients, immunotherapy, first-line therapy compared to chemotherapy. And you can see that 6-month survival and 12-month survival, 50% for the chemotherapy arm compared to almost 65%, with the hazard ratio for death of 0.59 in favor, of course, of the atezolizumab arm. These are for the patients who overexpress PD-L1, that is greater than or equal to 50% expression in the tumor cells, although we do see atezolizumab also resulting in improved 12-month survival, 60% compared to 50% in patients who have intermediate PD-L1 expression, and although not as robust, some improvement in patients who have low expression to PD-L1. Atezolizumab has recently been approved by the FDA as another agent in the first-line treatment of advanced non-small cell lung cancer in patients who overexpress PD-L1. The combination or the rationale for combining immunotherapy and chemotherapy is based on several factors. Chemotherapy may stimulate anti-cancer immunity by inducing cell death, and that in turn releases antigens which can activate the dendritic cells that then present to the lymphocytes. And it can also increase the ratio of cytotoxic lymphocytes to regulatory T cells. The first study combining pembrolizumab and chemotherapy versus chemotherapy alone in patients with untreated metastatic non-squamous non-small cell lung cancer. Again, these are patients, but the majority have adenocarcinoma who do not have any molecular expression in their tumor. Patients were randomized to platinum pemetrexate chemotherapy, which is the standard of care, versus chemotherapy and pembrolizumab. The combination of pembrolizumab and chemotherapy in non-squamous non-small cell lung cancer resulted in a significantly overall survival at 1 year, 69%, compared to 49% for the chemotherapy group alone. The benefit of the combination of pembrolizumab and chemotherapy was seen across all categories of PD-L1 expression, but the greatest benefit was seen in patients who overexpress PD-L1. More importantly, there was no increase in the frequency of chemotherapy adverse event and no difference in immune related events between the two groups, the placebo group and the immunotherapy group. The combination of pembrolizumab plus chemotherapy was then investigated in patients with advanced squamous cell carcinoma of the lung. And squamous cell carcinoma of the lung accounts for about 20 to 30% of all new non-small cell lung cancers. It has a worse prognosis than adenocarcinoma of the lung. To date, we have not identified any targeted molecular targets in squamous cell carcinoma. The combination of pembrolizumab and chemotherapy versus chemotherapy alone was studied in 559 patients with advanced squamous cell carcinoma. And again, as we saw with the non-squamous cell group, the combination of pembrolizumab and chemotherapy resulted in improved overall survival compared to chemotherapy alone, a hazard ratio of 0.64. Again, in a subgroup of patients, squamous cell, which have a worse prognosis. And more importantly, we see the benefit across all levels of PD-L1 expression. The combination of PD-1 inhibitor, nivolumab, and CTLA-4 cytotoxic lymphocyte 4 antigens, so both the central and peripheral checkpoint inhibition has been evaluated, and we have recent data of the combination of nivolumab and ipilimumab compared to nivolumab and chemo alone and chemotherapy alone in patients with advanced non-small cell lung cancer. And in the green line here in the survival curve, this is the combination of nivolumab and ipilimumab. And although not as dramatic as we saw, for example, in the pembrolizumab trials, nonetheless, an improvement in 2-year survival for patients who were treated with combination of a PD-1 inhibitor and CTLA-4 inhibitor, and more importantly, longer duration of overall survival. And importantly, it was seen across multiple characteristics, so age, female sex, but importantly, not appreciated the survival benefit in patients who had never smoked or in patients with liver metastases at the time of enrollment. So another option for patients with non-small cell lung cancer. Immunotherapy has also been studied in unresectable stage 3A non-small cell lung cancer. And as many of you know, for many, many years, the treatment of unresectable stage 3A centered around concurrent chemotherapy and radiation. This was based on a very important study that was reported in 2011 that demonstrated that the concurrent approach, so together the chemotherapy and radiation compared to sequential one after the other, resulted in improved 5-year survival in patients with unresectable stage 3. But 5-year survival was anywhere between 15 and 20%. And the standard of care for many, many years had been concurrent chemotherapy and radiotherapy, but we were never really able to make much improvement in that 5-year survival in stage 3A unresectable disease. So a new approach was very much needed. And that new approach was looked at with the addition of immunotherapy, PD-L1 inhibitor, durvalumab, following completion of concurrent chemotherapy and radiotherapy. This was a multi-institutional, multinational, many countries were involved, 709 patients who had undergone concurrent chemotherapy and radiotherapy for unresectable stage 3, and who were deemed to have no evidence of progression of disease after they had completed their therapy. And patients were randomized to receiving adjuvant durvalumab, which was the investigation arm, versus a placebo, which had been the standard of care. We completed therapy and we would just watch these patients. And the primary endpoints were progression-free survival and overall survival. And this was really impactful because the addition of durvalumab after completion of concurrent chemotherapy and radiotherapy resulted in significant improvement in progression-free survival compared to placebo, with a hazard ratio of 0.52. Clinical meaningful benefit in overall response rate, and more importantly, a lower incidence of newer lesions, newer metastatic disease, including new brain metastases, which has always been sort of the more concerning site of recurrence after concurrent chemoradiotherapy because of the poor penetration of chemotherapy across the blood-brain barrier. The results of the Pacific trial were updated and reported in 2018. Not only the primary endpoints, which had been progression-free survival and overall survival, but more importantly, time to death or time to distant metastases, and the safety of the two approaches. And again, after concurrent chemoradiotherapy, the addition of durvalumab versus placebo resulted in improvement in 2-year survival, 55% compared to 66%. But more importantly, the time to progression, particularly brain metastases, was significantly improved in patients who had received durvalumab compared to placebo. Grade 3 and 4 adverse events were similar between the two arms. The rate of pneumonitis was greater in patients who had received durvalumab, and about 15% of patients in the durvalumab arm had to discontinue the drug due to adverse events. So slightly more complications in terms of pneumonitis primarily, but a significant improvement in median overall survival, 12-month and 24-month survival. And durvalumab, after concurrent chemotherapy and radiation for unresectable non-small cell lung cancer, is now the standard of care in patients who have no contraindications to being treated with immunotherapy. More recently, data is emerging on the role of immunotherapy in early stage 1 and 2 non-small cell lung cancer. These are patients who either undergo surgery followed by adjuvant chemotherapy or neoadjuvant chemotherapy followed by surgical resection. Immunotherapy administered in combination with neoadjuvant chemotherapy may potentially induce an anti-tumor response that persists even beyond surgery, and thus preventing recurrent disease. There are multiple different trials that are ongoing looking at various immunotherapy drugs: pembrolizumab, durvalumab, nivolumab, atezolizumab, and canakinumab, which is a new agent. And this is really exciting because this is yet another opportunity to improve overall survival. We know that particular patients with stage 2, when the disease has metastasized to higher lymph nodes, although surgical resection is the standard of care, followed by adjuvant therapy. Adjuvant therapy provides a benefit in overall survival, but it's a small benefit. And it's quite hopeful that the introduction or the combination of chemotherapy and immunotherapy in this subset of patients will further improve overall survival. More importantly, has been the introduction of immunotherapy in small cell lung cancer. As many of you know, small cell lung cancer accounts for about 15 to 20% of all lung cancers that are diagnosed each year. The majority of these patients, over 75%, are diagnosed with advanced disease or extensive stage disease. For decades, the only option that we had was systemic chemotherapy with a reasonable response. This is a very chemosensitive tumor, but overall outcome very poor with very high rates of disease progression. No 5-year survival, no 2-year survival, median survival about 10 months for those patients who responded to chemo. And not much progress had been made for almost 20 years in this disease. This was the first study that evaluated the role of atezolizumab plus chemotherapy in the first-line setting for patients with extensive stage small cell lung cancer, compared to standard of care, which is platinum plus etoposide. And for the first time ever in a long time, we appreciated improvement in overall survival at 12 months in patients with extensive stage small cell lung cancer treated with the combination of chemotherapy and immunotherapy compared to chemotherapy alone. There were no difference in toxicity between the two groups, slightly more adverse events in the atezolizumab group compared to the placebo group, but nonetheless, an important step in the right direction in a subset of patients who for decades really had very, very little options other than systemic chemotherapy. December of 2019, I believe, we had the second study demonstrating the benefit of immunotherapy when added to chemotherapy in the first-line treatment of patients with extensive stage disease. This was a study that enrolled 537 patients who had never received any chemotherapy. This was again across many, not only sites, but across 23 countries. The primary endpoint of this study was overall survival. And again, the combination of durvalumab, PD-L1 inhibitor, with systemic chemotherapy compared with systemic chemotherapy alone resulted in improved overall survival with a hazard ratio for death of 0.73, favoring the durvalumab plus etoposide. 34% of patients treated with durvalumab and chemotherapy were alive at 18 months compared to 25% in the chemotherapy arm. And there was no difference in adverse events. And importantly, the benefit of durvalumab plus chemotherapy was seen across all age groups, men and women, in, of course, smokers, because this is a disease of individuals who smoke, but more importantly, across countries and different races. So a second study that provides significant hope in small cell lung cancer, which again, for many, many years had really very little options in terms of treatment. In summary, lung cancer remains one of the most lethal illnesses known to humankind. It is a leading cause of cancer death in the United States and in many other countries. The majority of patients who are diagnosed with lung cancer are diagnosed with advanced disease. Approximately 55% of non-small cell lung cancer patients will present with stage 4 disease at the time of diagnosis, and more than 75% of patients with small cell will present with extensive stage disease at the time of diagnosis. And for decades, while we had made some progress with systemic chemotherapy in both subsets of lung cancer groups, and importantly, we made significant progress with targeted therapies in adenocarcinoma. A large portion of patients, those who did not harbor molecular alterations, those with squamous cell carcinoma of the lung, and those with small cell really had very little options. There's no doubt that the introduction of immunotherapy into the treatment paradigm of non-small cell lung cancer and small cell lung cancer has really changed the outcome for many of these patients in terms of not only progression-free survival and time to development of metastatic disease, but again, for the first time in a long time, we can say that we have 5-year survival in a subset of patients with non-small cell lung cancer treated with immunotherapy for metastatic disease. It is now the standard of care for patients with metastatic disease. Importantly, to identify the expression of PD-L1 so that we can select those patients who should be treated with first-line pembrolizumab or now atezolizumab. Important to identify patients without disease progression after concurrent chemotherapy and radiation in stage 3 because now durvalumab is the standard of care following completion of therapy in those patients. And hopefully soon we will have results of the impact of immunotherapy on the treatment of early stage non-small cell lung cancer. And I hope more studies that will investigate the role of immunotherapy, not only in advanced stage small cell, but even in early stage small cell lung cancer. Thank you very much.
And thank you, Patricia. Very special talk showing us the light at the end of the tunnel. And we're really anticipating really these new studies that you're mentioning. But Patricia, you've shown us a tremendous challenge we have. The challenge we have is remembering all these names of these new agents. And the second, even more difficult, is how do we pronounce these agents? So with that, let me say that the phone line is open if anyone has any questions. I see one over here. Since many cases will be found incidentally when scans are done by, is that you? No, let me say, I'm sorry. Was that your question? I would follow up. Okay, let me, I think I know what he's asking. So, a quick question. Obviously, we're in the age of a patient-centered approach to therapy. So how do you approach the shared decision-making with patients? What's the conversation, the discussion that you have as you approach them with these new immunotherapy agents?
Thank you, Sid. Thank you for inviting me to present at the meeting. I think that one of the most important discussions to have with patients regarding treatment in stage 4 non-small cell lung cancer is the appreciation that it isn't just about immunotherapy, but one of the most important steps that we must take is determining whether the tumor harbors molecular mutations or molecular characteristics that might be amenable to specific targeted therapies. And that's often very difficult for patients because they're bombarded with all of these commercials about immunotherapy, and often patients will come and say, I want immunotherapy, when really the most important thing we have to do is to ensure that if it's a patient with adenocarcinoma or if it's a patient with squamous cell carcinoma who is of young age, less than 50 years of age, and minimal smoking history, that we must first analyze tumors to ensure that targeted therapy is in the right first choice. Because that's a big mistake to make, to treat an individual who harbors a molecular mutation with immunotherapy first. Those patients should always receive the targeted therapy first. So that's often an important discussion, and it's difficult because it can take up to 2 weeks, sometimes longer, for us to have the results of molecular characterization of tumors. So it means often delay in treatment, which can be very difficult for patients who are recently diagnosed with stage 4. But we know that if the patient is not overly symptomatic, that there is time to wait. So that's probably one of the most important decisions in the stage 4 setting, which is where the majority of these immunotherapy agents play a major role. In the stage 3 setting, I think that's a little bit different. The standard of care is concurrent chemotherapy and radiation up front. And then if there is no evidence of disease progression after the patient has completed that therapy and they have had no significant adverse events, then durvalumab is important because it really has shown to improve overall survival and improve recurrence of disease, particularly with brain metastases in patients in stage 3. So they're difficult discussions, but I think it's very important to ensure that patients understand the benefits of waiting for molecular characterization and the role that that immunotherapy plays if they don't have a mutation or if they do have a mutation. And then, of course, the other issue is really The toxicity associated with these agents, although minimal in the real world setting, we know that immunotherapy or immune checkpoint inhibitor related pneumonitis has a higher incidence of what was reported in the clinical trials. And there are certain characteristics, particularly pulmonary fibrosis, whether it be septal thickening or fibrotic changes, ground glass opacities, that can predispose individuals to immune checkpoint inhibitor related pneumonitis. So those discussions are also very important to have with patients.
Yeah. I'm glad you brought up that latter point because this is certainly where very often the oncologist and the pulmonologist will be beginning to work together with these patients.
Yes.
When there is pulmonary toxicity, the questions on the phone is, gee, can I continue therapy? Can I restart the therapy? What are your recommendations at this point?
It's, they're well, we have recommendations that have been published by ASCO in the journal Clinical Oncology in 2018, which were very, very helpful. The most important thing that we as pulmonologists need to do is to help differentiate grade 1, grade 2, grade 3 pneumonitis. I think understanding the distribution of infiltrates, how much of the lung is involved, the nuances of symptoms, which are often not picked up by clinicians other than pulmonologists because, oh, it's a lung cancer patient. Of course they have shortness of breath. Of course they have cough. But I think we're a lot better at determining whether there's been a change in symptoms and also being able to obtain physiologic data if we have pre-treatment data that we can compare to, such as vital capacity, transfer factor, and 6-minute walk test. But the recommendations for grade 1 pneumonitis, which is an asymptomatic patient with radiographic findings that involve less than 25% of the lung, is really to hold the drug, or in some cases, you can even continue the drug. I think once you get to stage 2 or grade 2 pneumonitis, which is a patient who is symptomatic, although not impairing activities of daily life, and a patient who has greater than 50% of lung involvement, the appropriate thing is to hold the immunotherapy drug and to initiate treatment with systemic corticosteroids. Grade 3, obviously, those patients who are quite symptomatic, hypoxemic, significant radiographic involvement, and often those patients may require hospitalization. The big challenge, I think, for me and for many medical oncologists is in grade 2 pneumonitis, can you restart the immunotherapy drug? We know that in grade 1, there are some studies that support that it's safe to restart. Most patients are not, do not develop worsening symptoms. In grade 3, it's contraindicated. But grade 2 is a gray zone, and we just don't have enough data. For me, it's really about the overall involvement, whether or not, how symptomatic patients are, whether they respond to steroids, not just with symptom improvement, but also physiologic improvement and radiographic improvement. And I think it's prudent to wait after individuals have completed steroids. The recommendations are steroids over 4 to 6 weeks with a slow taper, because we are seeing more and more patients with particularly grade 2 pneumonitis who respond wonderfully to steroids, and then within a week or so after completing steroids will flare. And that's something that's emerging. Our group, we have an immunotherapy related working group with physicians from all the different specialties. And I'm currently putting together a group to work with individuals from Johns Hopkins who see a lot of this and have reported on this, to think about how we can put together patient outcomes and report on this. But recurrence after treatment with steroids is being seen a bit more frequently, and I think we have to be careful about restarting immunotherapy after completing steroids, ensuring that patients don't relapse after steroids.
One last question. This is from Dr. Trapnell. On which cell type is PD-1 signaling most important?
The lymphocyte the peripheral lymphocytes, so the lymphocytes and lymph nodes, as opposed to the CTL4, which are in the central organs, such as the thymus. So it would be in the surface of the T lymphocyte.
Great. Patricia, always wonderful to see you, even though it's from a
Thank you so
distance.
much.
And
Yes.
it's a great discussion and presentation. Thanks so much
Thank
for
you. Thank you,
helping
sir.
us out. Okay, we are now in the third section of our symposium this morning. This is a very exciting moment for me because I'm ready to introduce an old colleague, someone who I worked with for many years at Brown University, Dr. James Klinger. Dr. Klinger is a professor of medicine at the Alpine Medical School at Brown University. He's also the medical director of Rhode Island Hospital Pulmonary Hypertension Center. Jim's discussion this morning is going to be clinical updates for the management of patients with pulmonary arterial hypertension. Jim, take it away.
Good morning, everyone. I'm Dr. Klinger from Rhode Island Hospital. I'm happy to talk to you today about updates for the management of patients with pulmonary hypertension. This is the agenda that we will be going over today in the talk. These are our learning objectives, and I'll highlight these shortly in another slide. This program is approved for CME credit. These are my disclosures. I receive research in the form of a grant support for research studies from United Therapeutics, excuse me, and I am also an unpaid consultant for Bayer Pharmaceutical. This CME activity was supported by an independent educational grant from Actelion Pharmaceuticals and is approved for academic CME credits. So what I'd like to talk to you about today is the overall approach to the treatment of patients with pulmonary arterial hypertension. And I'm going to divide this talk into 4 parts. 1, diagnosis of patients with PAH. 2, the characterization of patients with pulmonary arterial hypertension. And this is important as it impacts on how we treat them. And then 3, the most recently published treatment algorithms that tell us how to use different medications to treat these patients. And finally, what we do after we start treatment to monitor the patient's response and then adjust therapy from there. So even though most of this talk is supposed to be about treatment of pulmonary hypertension, I think it's critically important that we take some time to ensure proper diagnosis. And this is important for several reasons, but primarily because 1, the disease that we're going to be treating is extremely rare. The medications that we have available are effective, but do not reverse the disease. And third, they are extremely expensive and have a fairly significant side effect profile. So it's very important that we don't use them to treat patients who are not likely to respond to them. One of the problems that we have with the disease is the nomenclature. So you are all familiar with the term pulmonary hypertension, as is many of our patients. But there's a difference between pulmonary hypertension and this rare disease that we call pulmonary arterial hypertension. And I've tried to diagram these for you in the slide. So to the left, you can see pulmonary hypertension. This is a very common condition that's associated with chronic heart and lung diseases, and it's managed by treating the underlying heart and lung disease. Whereas pulmonary arterial hypertension is an extremely rare disease that's characterized by an abnormal remodeling of the distal pulmonary circulation. And even though it's rare, it's responsible for the development of over a dozen drugs in the last 20 years. And this is the rare disease that we're going to be talking about. Now, previously, these diseases used to be distinguished from each other by calling them primary pulmonary hypertension or secondary pulmonary hypertension. And the problem with this nomenclature is that there are a variety of diseases that are associated with pulmonary arterial hypertension, including connective tissue diseases, HIV infection, portal hypertension, congenital heart diseases, and the use of anorectic drugs or methamphetamines. And so it was not uncommon in the past to refer to these conditions as pulmonary hypertension secondary to HIV infection or connective tissue disease. So to get rid of the whole designation of primary and secondary pulmonary hypertension, the World Health Organization switched to this nomenclature of pulmonary arterial hypertension, meaning that the disease was a disease of the pulmonary arteries and distinguishing it from other types of pulmonary hypertension. To give you kind of a brief history of how this looks, history of pulmonary hypertension probably begins in about 1891 when the Dutch pathologist Ernest van Romberg first described a case of what he described as pulmonary arterial sclerosis in a young woman who had died unexpectedly. And what he found at autopsy was that the pulmonary arteries were diffusely impacted by sclerosis of the distal part of the circulation. And perhaps it would have been good if we would have maintained this term throughout the years, because then we would know exactly what it is that we're talking about. But about 100 years later, as the clinical syndrome became better understood in medicine, it was described as primary pulmonary hypertension, again to indicate that the disease was a primary disease of the pulmonary arteries. And then this disease was very rare and not very well recognized until the 60s and 70s, when there was this outbreak in Europe caused by contaminated rapeseed oil, when many people came down with this disease, and that prompted the NIH to start a registry in the United States in the 1970s. In 1973, the World Health Organization convened the first World Symposium on Pulmonary Hypertension. And in 2003, that conference, which occurs about every 5 years, developed the current nomenclature that we have that describes the various types of pulmonary hypertensive diseases. And so this grouping has been called the World Health Organization grouping, or the WHO grouping. And it was most recently modified in 2018 in Nice, France. Now, the definition of pulmonary hypertension is elevated pulmonary arterial pressure. Normally, the pulmonary arterial pressure is much lower than the systemic pressure, and usually averages about 14 millimeters of mercury with a standard deviation of about 3. That would result in a top normal, that is 2 standard deviations above the mean, of being 20.6 millimeters of mercury. And so for many years, there was this kind of gray zone between people who were just above 2 standard deviations at 21, but not at the 25 millimeter of mercury definition of pulmonary hypertension. And we weren't sure what to do with them. But this was the accepted definition, that to have pulmonary hypertension, you had to have a mean PA pressure greater than 25. At the same time, you were supposed to have a left ventricular end diastolic pressure of 15 or less if you were to have pulmonary arterial hypertension. And this would normally translate into a pulmonary vascular resistance of greater than 3 Woods units. There was also this question of what do we do with a mean pulmonary arterial pressure that goes up during exercise? And many people thought that it would be best to call pulmonary hypertension an increase in mean pulmonary arterial pressure greater than 30 millimeters of mercury. There are other ways to look at pulmonary arterial hypertension well, and that was whether or not the transpulmonary pressure gradient was elevated, or whether or not the difference between pulmonary arterial diastolic pressure and pulmonary capillary wedge pressure was elevated. And so here again, somewhat arbitrary cutoffs of a mean PAP to wedge pressure gradient of greater than 15, or a pulmonary artery diastolic to pulmonary capillary wedge pressure gradient greater than 7 as being abnormal and considered as pulmonary hypertension. So in 2018, there was a special task force that was assigned the job of determining the final definition of pulmonary hypertension. And at that meeting, they agreed that the definition of pulmonary hypertension should be a mean PA pressure that is greater than or equal to 20 at rest, and that pulmonary arterial hypertension should be defined as a mean PA pressure greater than 20 with a pulmonary venous pressure measured either by pulmonary capillary wedge pressure, left atrial pressure, or left ventricular end diastolic pressure as less than 15 millimeters of mercury. They also suggested that they include in that definition a pulmonary vascular resistance greater than 3 Woods units. And then they broke down the various types of pulmonary hypertension into this list that you see here. This list has been in existence for more than 15 years now. It was very slightly refined in the last meeting, but in general, we're talking about pulmonary arterial hypertension as being group 1, pulmonary hypertension due to left heart disease as group 2, pulmonary hypertension due to lung disease as group 3, pulmonary hypertension due to chronic thromboembolic disease as group 4, and then the rest were in a miscellaneous causes that we described as group 5. Now, we have to remember that more than 95% of patients with pulmonary hypertension don't have pulmonary arterial hypertension. In fact, pulmonary arterial hypertension makes up of about 2 to 3% of all causes of pulmonary hypertension. And that's why it becomes very important to find out who these patients are. We can do this by hemodynamic definition, but it only gets us so far. All of the groups of pulmonary hypertension have to have the same mean PA pressure criteria, which is a PA pressure greater than 20 at rest. Only group 2 is different from the other 5 groups as having a requirement of a pulmonary capillary wedge pressure that's greater than or equal to 15. So we can't distinguish group 1 from group 3 or group 4 or group 5 by hemodynamic criteria alone. The pathologic definition of pulmonary arterial hypertension is this diffuse remodeling of the distal pulmonary circulation that you see here, characterized by endothelial cell proliferation, thrombosis in situ, hypertrophy and proliferation of the pulmonary vascular smooth muscle layer, or the plexiform lesions that are pathognomonic of the disease. However, in order to get this diagnosis, the patient requires open lung biopsy, and the biopsies have to be done in multiple places throughout the lung, which is dangerous in a patient with pulmonary hypertension. So as a result, we rarely do a biopsy on a patient to make a diagnosis of pulmonary arterial hypertension. Instead, we rely on a rather diffuse set of different clinical tests in order to determine, or I should say to rule out, the presence of chronic heart or lung disease or other causes that would be responsible for the patient developing pulmonary hypertension. And when we can find no other presence of chronic heart or lung disease or thromboembolic disease, we then describe the patient as having pulmonary arterial hypertension. Now, the importance of this cannot be stressed enough. As you can see here, the 5 different types of pulmonary hypertensive diseases are all treated considerably differently, right? So if we have this rare disease that we call group 1 pulmonary hypertension, we have quite a few drugs, which we're going to talk about for the rest of the presentation and how those can be managed. However, if they have group 2, group 3, group 4, or group 5, they're treated with an entirely different group of drugs, and they may require different treatments such as mitral valve or aortic valve replacement, or even in the case of chronic thromboembolic pulmonary hypertension, a pulmonary artery endarterectomy. Let me just give 2 slides very quickly about the diagnosis of chronic thromboembolic pulmonary hypertension. This is a rare disease, but not any more rare than group 1 pulmonary arterial hypertension. It can be diagnosed by a high prob VQ scan, or by chronic thrombo, or by a CT scan looking for pulmonary hypertension. I would just point out that this disease is potentially curable, unlike group 1 pulmonary arterial hypertension, with an operation that we call a pulmonary endarterectomy. So we don't want to miss this disease because we can significantly impact the patient's outcome. The other thing I wanted to point out is that up to a half of patients with chronic thromboembolic pulmonary hypertension do not have an apparent history of acute PE. So the fact that a patient never had a pulmonary embolism or DVT that they're aware of does not mean that they don't have the disease. So all patients with pulmonary hypertension need to be screened for chronic thromboembolic pulmonary hypertension prior to treatment. All right. After we've made the diagnosis of pulmonary arterial hypertension, it's important to find out what our patient is like. We call this patient characterization. And there are 2 primary things we're trying to accomplish here. One, are they a rare type of patients with pulmonary hypertension that manifest an acute vasodilator response? And 2, what is their overall risk of not surviving the next year? We'll go into each of these in more detail. So the acute vasodilator response is defined as a patient who will drop their mean pulmonary arterial pressure at least 10 millimeters of mercury and have a mean PA pressure that falls below 40 millimeters of mercury with no decrease and preferably an increase in cardiac output. If they do not have all 3 of these, then they do not have an acute vasodilator response. And I'll show you what this looks like. This is a patient who has a mean pulmonary arterial pressure of 56 at rest. You see this over on this side. In response to inhaled nitric oxide, they drop that mean PA pressure down below 40, and they have an increase in their cardiac index. So this patient has a positive vasodilator response, and as a result, they are treated differently than a patient that does not have this response. As far as risk stratification is concerned, there are no definitive criteria like we have with acute vasodilator response. Instead, we have this table of good signs and bad signs that will prognosticate the patient's chance of 1-year survival. People who have the green column here, which has the absence of a lot of these bad prognostic indicators, are considered to be at low risk of early mortality in the next year, approximately less than 5%. And people that have all of these things in the red column over here have a high risk of 1-year mortality. So these are obviously the patients that we want to treat most aggressively, and these are the patients that can get by with less aggressive therapy. Now, of course, patients may have features of all 3 columns. You may have a patient that has some features in the green column, some in the yellow column, some in the red column. The more you have in the red column, the more these patients should be treated aggressively. And we'll go through that in the treatment algorithms. But you will see very early in the treatment algorithms risk assessment. And when you see that term risk assessment, this is the table that we're talking about. One of the most important parts of the risk assessment is the WHO functional class. The arrow doesn't come up quite high enough here, but WHO functional class has been shown to have a very important impact on outcome. And this is shown in this study that was published many years now, but you can see if your functional class is good, functional class 1 is normal, functional class 4 is very poor. These are the functional classes that come from the New York Heart Association. Functional class 1 is basically no symptoms. Functional class 2 is people who have shortness of breath with ordinary activity. Functional class 3 is shortness of breath with less than ordinary activity. And functional class 4 is shortness of breath with any activity or even at rest. And you can see the worse your functional class, the worse your survival. This is a more modern approach to risk stratification. This is something called the Reveal 2 risk score. This is a program that you can actually download on your phone. It asks you different questions about the characteristics of your patients. You get assigned a certain number of points based on the different clinical characteristics that the patient has, and then you get a total risk score. And if you have a risk score that's between 0 and 6, you can see that your risk of a 12-month survival is very good. If you have a score that's very high, greater than 13, you can see your risk is very poor. And this can now be applied out to almost 5 years of survival. And again, low risk, very good survival, high risk, very bad survival, and a whole bunch of survival risks in between. But characterizing these patients by their clinical risk factors allows us to determine what type of therapy they need. All right, so let's talk about our modern treatment algorithms. Over the last 5 years, there have been 3 different groups that have published rather extensive treatment algorithms for pulmonary arterial hypertension. They describe how to use this group of approximately 12 different drugs that have been developed since 1995. All of these drugs attack 3 basic pathways. They include the endothelin pathway. Endothelin is a very potent pulmonary vasoconstrictor, so the idea here is to block the endothelin receptors. Cyclic GMP pathway. Cyclic GMP is a cellular mediator that helps regulate intracellular calcium and thereby relaxes pulmonary vascular smooth muscle. You want cyclic GMP to be high in the pulmonary vascular smooth muscle cells. This can be accomplished by things that attack, or I should say stimulate, soluble guanylate cyclase. This includes the soluble guanylate cyclase stimulators. Or it can be done by inhibiting the breakdown of cyclic GMP by inhibiting the primary enzyme that metabolizes cyclic GMP, which in the lung is phosphodiesterase type 5. So we use a phosphodiesterase type 5 inhibitor. And then the third pathway is the prostacyclin pathway. Prostacyclin and its receptors result in an upregulation of intracellular cyclic AMP, and prostacyclin derivatives can be used to increase cyclic AMP in this way, or there is now a prostacyclin receptor agonist that is available, which is not a prostacyclin derivative. So this encompasses all 3 pathways and includes 5 different types of drugs. So these are the guidelines. In 2015, the European Society of Cardiology and the European Respiratory Society came out with their guidelines for treatment of pulmonary hypertension. In 2019, the World Health Organization, the World Symposium on Pulmonary Hypertension in Nice, France, published their guidelines. And then several months later, in March of 2019, the American College of Chest Physicians published our guidelines on the treatment of pulmonary hypertension. All 3 of these guidelines basically look like this. Now, this is the actual algorithm that's taken from the World Symposium on Pulmonary Hypertension. It was published in January of 2019. And what they say is the following. The first step is to determine whether or not your patient has an acute vasoreactive response. If they do, these patients can be managed with calcium channel blockers. If the patients do not have a vasoactive response, and this includes about 90% of patients with group 1 pulmonary arterial hypertension, they should then be divided into the low intermediate risk group or the high risk group. And these are the colors that are taken from that table. If you remember, people that have features in the green or yellow columns are considered to be at low or intermediate risk, and people that have mostly features in the red column are considered to be at high risk. Those patients then are stratified into either initial oral combination therapy, which I'll show you in just a minute, or initial combination therapy that includes a parenteral prostacyclin analog. Those patients are then assessed 3 to 6 months after the initiation of treatment, and depending on their response, more medications are either added or taken away. But let's go through the first part here. So the evidence that suggests that patients should be treated with 2 agents as initial therapy comes from this trial known as the Ambition trial that was published in 2015. And what this study did is it took a large number of patients and it randomized them to receive either a phosphodiesterase inhibitor alone, or a endothelin receptor antagonist alone, or a combination of the 2 together. And then what it did is it followed these patients for several years and looked at the time to first clinical worsening. And you can see that patients who were started initially on combination therapy had fewer events suggesting a progression of disease compared to all of the patients who received either ambrisentan alone or tadalafil alone. And from this study, it was decided by these different groups that have come out with these treatment algorithms that the best approach to patients with pulmonary arterial hypertension is to start them on upfront combination therapy with an endothelin receptor antagonist and with a phosphodiesterase inhibitor. All right. Now the question becomes, what happens if the patient doesn't get better? And this is the second part of the algorithm here. So after 3 to 6 months of treatment, we should reassess them and see what has happened to their risk stratification. Did they go to or stay in a low risk category? If they did, we can continue their therapy. However, if they went to an intermediate or high risk category, that is to say, if they progressed from low risk to intermediate risk or from intermediate risk to high risk, then they need additional therapy. Now, in the past, we used to do this one at a time. So we would start our patients on an endothelin receptor antagonist or a phosphodiesterase inhibitor. And if they did not reach their treatment goals, which we defined as a functional class of 1 or 2, a 6-minute walk test greater than 440 meters, a BNP less than 50 or a pro-BNP less than 300, a right atrial pressure less than 8, or a cardiac index greater than 2.5. If they did not reach those treatment goals after 3 to 6 months of therapy, then we added the second agent. So if they were on an ERA, we would add a phosphodiesterase inhibitor. If they started on a phosphodiesterase inhibitor, we would add an endothelin receptor antagonist. Nowadays, we're recommending the combination of an ERA and a phosphodiesterase inhibitor as initial therapy. So if they don't reach these treatment goals by 3 to 6 months of therapy on a combination of these 2 medications, now the options about what we can add are more limited, but they include an oral or inhaled or parenteral prostacyclin or a prostacyclin receptor agonist. And then of course, if those don't work, the patient is now on triple therapy. And if they do not respond, the only additional therapy we have left is lung transplantation. Let me just show you the impact of clinical worsening on survival. You can see here the definition of clinical worsening is an increase in their functional class. So if their functional class worsens, more than a 15% fall in their 6-minute walk test, any type of hospitalization, or the need to initiate parenteral therapy. Those patients that required any of these things had a significantly worse survival than patients who did not. And because of this, the theory is if we can prevent this from happening, we can improve survival. Now, it's not clear if that actually happens. That is to say, it's possible that what we're seeing here is that patients who have less severe disease or patients who are capable of responding to treatment simply fall into this category. That is to say, they do not have any of these events over the first 3 to 6 months of therapy. And therefore, it may not be possible to make them better by increasing therapy. But at this point, we hope that that's possible. And so the idea is to try. This is another example. This is data that was published a couple of years ago, looking at overall survival in people who were able to stay free of any event during the first 3 of therapy. So this is data from the Seraphim trial, which looked at mesatentin. This is data from the Griffin trial, which looked at the use of the drug selexipag. In these trials, people who met these criteria within 3 months had this survival or this mortality, and people that did not hit any of these criteria that suggested disease progression were much more free of death over the next several years. So again, this is indirect evidence, but it suggests that if we can get people into this low risk category, they're going to do better overall. These are data from the selexipag therapy, and I just show these to you because this is one of the more recent trials of pulmonary hypertension. This looks very much like the data that you saw from the Ambition trial. It's kind of interesting because in this study, the majority of the patients were on background therapy already and then had selexipag added to their therapy. And as you can see, they had resulted in an improvement in a delay in time to clinical worsening. This is also true for oral treprostinil. This is the most recently approved drug. And this clinical trial was published earlier this year. And again, you can see patients mostly were on background therapy to begin with, and when they failed to reach their clinical endpoints, the addition of oral treprostinil resulted in a delay in time to clinical worsening, suggesting again that both of these therapies can be effective when added on to upfront combination therapy. Now, there's another alternative that also presents itself, and that is we have a number of drugs now that result in multiple combinations, and it's possible, therefore, instead of adding therapy to upfront combination therapy, we could switch one of the therapies. And this has been tried in a couple of recent clinical trials. One is about to be published, but one has already been published, but they examine the same thing. So these are data from the RESPITE study. And the goal of the RESPITE study was to take people who had pulmonary arterial hypertension, who were treated just with a phosphodiesterase inhibitor, but who had not reached their treatment goals as defined below here, and switch them from their phosphodiesterase inhibitor to a soluble guanylate cyclase stimulator. So instead of preventing the breakdown of cyclic GMP, this study or this drug causes an increase in cyclic GMP production. Now you might say, why can't we use them both? And the answer to that question is because there was a study done where a patient received both an inhibitor of cyclic GMP breakdown and a cyclic GMP stimulator, and those patients had an increase in adverse events and no significant improvement in benefit. So it is presently contraindicated to use a phosphodiesterase inhibitor and a soluble guanylate cyclase stimulator such as riociguat. However, it is possible to switch them from a phosphodiesterase inhibitor to a soluble guanylate cyclase stimulator. And in this particular trial, that resulted in a significant improvement in 6-minute walk distance and a significant reduction in NT-proBNP. Now, this was an open label trial. This was not randomized and was not controlled. The RESPITE study has been repeated with an additional study known as the REPLACE study. And in that study, patients were randomized to either stay on their phosphodiesterase inhibitor or to be switched to riociguat. So it was a randomized study, but not a placebo-controlled trial. That was also a positive study that showed an improvement in the primary endpoint, was a positive response defined as an increase in 6-minute walk distance or a decrease in functional, NT-proBNP or an improvement in functional class. And that study result has been announced and will be published early this year, or early next year, I should say. All right. So if we put these all together, the way this is supposed to look is the following. We start by assessing our patient's risk factors for pulmonary hypertension. Do they have a low right atrial pressure, a normal BNP, a good 6-minute walk distance, and a functional class that's relatively low, meaning good functional capacity? If so, the recommendation is to start with a phosphodiesterase inhibitor and an endothelial receptor antagonist as upfront combination therapy. If the patient then starts to do better, they're all set. If they don't do better, then we have the option of either adding an inhaled or oral prostacyclin or the prostacyclin receptor agonist selexipag, or switching the phosphodiesterase inhibitor to riociguat. And then if they don't respond to that, we have the option of adding an inhaled or oral prostacyclin or the prostacyclin receptor antagonist. Then, of course, if they don't respond to any of these things, we have the option of adding a parenteral prostacyclin. And if that doesn't work, we go to lung transplant. And this should occur as the patient moves from a low to an intermediate to a high-risk category based on elevation of right atrial pressure, increasing BNP levels, decrease in the 6-minute walk distance, and a worsening of WHO functional class. Now, I've outlined these as black letters and blue letters because what you see in black here is the presently published and approved treatment guidelines. What you see over here in the blue letters is an alternative therapy that has not yet been adopted by the guideline committees. And that's because this therapy, as I said, is relatively new, and the most important trial is yet to be published. But we anticipate that over the next couple of years, when this data comes out, the alternative therapy of switching as opposed to be adding will be added so that you'll have the option of doing either. But right now, the present treatment algorithms suggest this start additional combination therapy up front and then adding the prostacyclin or prostacyclin receptor analogs as we go towards worsening clinical response, and then finally ending with intravenous prostacyclin or lung transplant. And then finally, I should say, if your patient starts off in a high risk, you skip all these steps and go right to this step. So a patient presenting to you who is at high risk, meaning they have these things, and particularly those patients who are in functional class 4, do not go through this treatment algorithm. They simply start here in the algorithm with an upfront combination therapy and an intravenous prostacyclin. And then when all therapy's there, the last approach is lung transplantation. So just to summarize and to go over the key points, the proper diagnosis of pulmonary arterial hypertension is imperative because this is a disease, one, that is rare, two, treatment is difficult, and we don't want to treat patients that don't have the disease. The choice of initial treatment is driven by the patient's functional class and their risk of one-year mortality as described by those risk factors that we discussed in the talk. Mild to moderate impairment of function with a high one-year survival, or I should say a high one-year survival, can be treated with combination oral therapy. You can consider monotherapy in those patients who have a reason that they do not tolerate combination therapy, but whenever possible, we prefer upfront combination therapy with oral agents. Severe impairment of functional class, such as functional class 4, or a high risk of one-year mortality, those patients should be treated with a parenteral prostacyclin in combination with oral therapy. And patients who do not attain low-risk status after 3 to 6 months of therapy should be given additional or alternative therapies. And that is the end of our talk, and I'm happy to take any questions. Thank you very much.
Jim, thank you very much. As usual, a very comprehensive and clear presentation. I'm sure all appreciate it. Let me start with the first question. I understand that in recent years, pulmonary rehabilitation has been suggested for these patients with PAH. It seems to me that as you increase your exercise, your heart rate goes up, your pulmonary blood flow goes up through, I guess, a pretty fixed pulmonary circulation. So does it help, and why does it help, and what are your thoughts? And lastly, can patients be, their insurance reimburse for pulmonary rehab?
Sure. So the answer to all those questions, Sydney, is yes. That is to say, it helps the patient. It can be reimbursed by insurance companies. The concern is the one that you raised, that by increasing blood flow through the pulmonary circulation, you would tax the right ventricle and lead to right ventricular failure earlier. It's been shown that that's not the case as long as it's moderate exercise, and that's why the pulmonary rehabilitation is recommended. Rather than saying to a patient, go to a gym and work out as you feel best, we want the exercise done under a coordinated way with healthcare providers involved. The goal here is to improve the rest of the body's ability to utilize oxygen. So the problem with pulmonary hypertension is you have a limited cardiac output. So if you can improve systemic circulation and systemic oxygen extraction and utilization, then you can get more workload out of the same cardiac output. And that's why we think it's beneficial. So it is something that's recommended for all of our patients.
Super, thank you. We just heard a discussion from Patricia Rivera from North Carolina on immunotherapy and lung cancer. And I asked her this question, which I think is very relevant to your field too. And that relates to shared decision-making in patients with pulmonary hypertension. Since we have, as you showed us, many drugs that are available, particularly in the prostacyclins, many delivery capabilities, how do you discuss this and the potential complications with your patients?
Yeah, great question. So this is the good news in the field of pulmonary arterial hypertension, is that we have lots of options now. And patients actually have made this very clear in their surveys, that they are interested in medications that improve quality of life. And so now, instead of simply measuring things like pulmonary arterial pressure and 6-minute walk distance, whatnot, there are a variety of studies that are looking at things that are favorable to the patient. Ability to get up and get out, ability to interact with other people, even things that we didn't usually think about, like sexual performance. And so now we are encouraging physicians to discuss with their patients how the treatments themselves impact their lives and what results in the best quality of life. So obviously, if you can get your breathing to be better with a continuous infusion medication, that might be important to the patient. However, if the patient's primary problem is not how far they can walk, then it might be a better quality of life if they use combination oral therapy. So it's nice to have the different options. I think, the responsibility and the role of the practitioner is to make sure that the patient understands the effect of the medications on prognosis, outcome, and survival. And then from there, they can modify the therapy that's best for them.
Super, Jim. Seeing no other questions, let me ask one a little bit aside in the field. And that relates to probably one of the most common things that we clinicians will see, and that is pulmonary hypertension secondary to left heart disease. Now, I understand that the vasodilators, and maybe you'll discuss this a bit, can have some adverse effects, but many of these patients, after chronic left heart disease, have remodeling in their pulmonary artery, in their vessels, in their pulmonary circulation. What's to be done? Obviously, optimize their heart condition, we know that, but what's on the horizon to help these patients, and especially some of the remodeling that occurs in their vessels?
Yeah, so there's no specific drug therapies that are on the horizon that I'm aware of. What we're looking at is how to use the presently available vasodilators in conjunction with treating left-sided heart disease. So what we've learned as these drugs have become more available is that the vasoconstriction that we see in the lung is protective of the left heart, but at a point it becomes counterproductive. And so the idea is to dilate up those blood vessels, allow more blood flow through the lungs, but not overwhelm the left heart at the same time. And this results in kind of very careful monitoring of patients' left-sided filling pressures in addition to their pulmonary arterial pressures. And so what we're doing is treating these patients with combinations of high-dose diuretics, drugs to slow left ventricular heart rate so that you can increase filling time, but at the same time slowly uptrade on the pulmonary vasodilators. And because they're difficult and because it varies considerably in terms of response from one patient to the other, this is the group of patients that we think are best served by being referred to areas that have expertise in treating pulmonary hypertension and heart disease.
Super. Seeing no other questions, once again, let me thank you, say hi to everybody at home, and we'll hopefully see you in the future. With that, we'll conclude the symposium, the Academic CME Symposium, and we thank you all for your participation today with our three speakers. Okay, guys, I think we did it. Safe trip home.